Hello, my dear friends. My name is Vivekanand Jha. I am a nephrologist, as many of you will know. I'm currently the executive director of the George Institute for Global Health, which is a healthcare research organization that does a range of healthcare research, including observational studies and clinical trials. I'm also the chair of Global Kidney Health at Imperial College London. Both in my current role at the George Institute and in my previous role as a faculty member at Postgraduate Institute of Medical Education and Research, Chandigarh, or PGI, as many of you might know this organization by, I have been involved in carrying out clinical trials and other types of clinical research, including randomized clinical trials, which is the best form of evidence generation that informs clinical practice. It is my firm belief that all of us should have grounding in clinical trials and should be involved in clinical trials and other types of clinical research, of course. So when Dr. Umesh Khanna asked me to talk to all of you about this topic, I readily agreed. It just took me a bit to get this recording done, for which I express my apologies. But also, I express my gratitude to the Mumbai Nephrology Group and Dr. Umesh Khanna and his team for giving me this opportunity. So, what I thought I will do is to perhaps break it down into two distinct topics. Firstly, I would like to argue to all of you to really uh, get this fact that doing clinical trials is important. Not only important, but it is perhaps our duty as well. Duty to our colleagues, but also duty to our patients who we uh, hope to serve. The second aspect is how to do clinical trials. So what I'm going to do in this specific talk is to focus on the first aspect, and perhaps we can come to the second aspect in a separate talk. So let me start by sharing my screen because I would like to make this point using a PowerPoint presentation. So here you go, right? So a few months ago, the Indian Society of Nephrology invited me to speak in its annual conference, and they gave me this topic, which is in front of you on the screen. Clinical care and research, are these the two sides of the same coin? What I did was to flip the topic around because, in my opinion, currently clinical trials and research are not considered to be the two sides of the same coin. But the argument that I would like to make, and hopefully will convince you by the end of this talk, is that there should be two sides of the same coin. But before we get into that, let's get a few definitions straight. So the first definition is of clinical care. What is clinical care? I think you and I will all agree that clinical care is the direct provision of medical treatment and services to the patients who we serve on a daily basis. Clinical research is a component of medical and health research. It is, mind you, it's only a component of the various types of research that happen in the field of medicine and healthcare. But it is intended to produce knowledge which is valuable for understanding human disease, preventing and treating illness, and promoting health. Another issue which we deal with on a daily basis, but perhaps don't articulate so well, is something that was said a long time ago by that very wise man, Dr. John Osler, that medicine is a science of uncertainty and an art of probability. Every time we make a decision, we try to resolve uncertainty to some extent, and our decision has probabilistic scenarios built into it in all possible situations. Let me illustrate this by this one simple clinical scenario where you can see that a mother has brought her young child to a doctor, and the doctor is intently on examining that child. So the only question that the mother has in her mind is, what treatment should I pursue to rid my baby of this illness which he or she is suffering from? But the doctor actually is holding several thoughts in his mind at the same time. So he's thinking, how do I find out what the baby has? What are the possible outcomes of whatever condition the baby is suffering from? And here comes the probability bit. What are the odds or chances of an outcome that I don't like or that I don't look forward to, such as perhaps development of a complication or even death in certain instances? And immediately he is thinking, how do I identify whether this patient is at risk of such an outcome? And having done that, he thinks, what are my choices given the situation I find myself in? And whatever choices I make, are there any downsides to implementing these choices? So another element of uncertainty and probability entering into this decision making. And the final question is that what is the course of action that reduces the odds of a bad outcome at the least cost? So here he's thinking not only of the monetary cost, but of the cost of, for example, the length of treatment and the possible side effects, etc. So that clinical vignette perhaps illustrates to you the point that patient care is always an experiment. All patients, they begin in a baseline state. That baseline state may have a different severity of situations, etc. And they will receive an intervention, and finally they will have an outcome, whatever that outcome is, perhaps recovery, perhaps death, or perhaps somewhere in between. So that's the clinical situation that we all deal with. Now, if we convert this into a research scenario, commonly we express our research questions into this format, which is called the PICO format, or the patient or population intervention comparison for C, and finally outcome for O. And they're all defined here. So for the P, we want to describe a group of patients which is similar to the patient that we have at hand, and what are their characteristics. An intervention is not only the treatment that we give, but also thinking of the prognostic factor or the exposure that the patient might have had, such as exposure to, let's say, an illness, exposure to pollution, and so on. And we always compare, even in our own heads. So in a clinical trial situation, we have a comparator group. But in clinical practice, we always think of giving one treatment versus giving another treatment. So we try to do that comparison in our own mind. And finally, what do we hope to accomplish, measure, improve, or affect? This is something which might come as a surprise to some of you, is something which is a bit of a hyperbole, but this is a statement which was made by one of the former deans of the Harvard Medical School in his commencement address to a group of medical students. He said, half of what we are going to teach you during your medical education is going to be wrong, and other half is going to be, of course, right. But he said that our problem is that we don't often know which half is which. This is really very important. And this remains a challenge even today, where we have much more evidence than we had at that time when that statement was made. And this is actually a very recent paper which examined many clinical practices which are quite established in our practice, which you and I might be following every day without thinking, because we have seen our colleagues, our teachers, our seniors doing the same thing. So in this analysis, Dr. Vinayak Prasad and Dr. Adam Sifu from the United States, they examined more than 2,000 articles from some very high impact journals like the New England Journal of Medicine, Lancet, etc. And they identified more than 1,300 articles which were related to a medical practice. For example, an intervention related to a device or a drug, etc. Out of these 1344, they found that 27% practices were quite established. And even though these practices were established, some investigators decided to test these established practices as well. And what they found is that 38% of these established practices, please note this number, 38% only, that these established practices were beneficial. And actually, a greater proportion of these practices, 40%, were either no better than not doing anything or not doing this, or even in some instances worse. And another 20% remained inconclusive. So what it meant was that 40% of established practices are actually even worse in some instances than doing something else. So which means that those practices should be stopped. And only about 4 in 10 practices, less than 4 in 10 practices, continue to hold uh, their own when tested again, even though these practices are established. So one example that I will give you from our own field, which is of nephrology, is in hemodialysis. So when I was a resident training in nephrology, we all at that time thought of dialysis as a revolutionary treatment, which it is. There is no doubt about it. And we thought that given the fact that our kidneys work 24 hours a day, around the clock, producing urine, but we do hemodialysis only for 4 hours a day, 2 or 3 times every week. And the global nephrology community thought logically that if we do more dialysis, the patient should improve, right? Or the patient should be better in many ways. Their outcome should improve, their survival should improve, etc. So this hypothesis was tested in this study called the HEMO study. And what actually they found is that if you gave high dose hemodialysis and compared that with standard dose hemodialysis, actually the patient survival did not improve. So this came as a bit of a surprise, not a bit, but quite a lot of surprise, but actually showed us the value of doing clinical research. If we had not done this research and we had only proceeded on the assumption that high dose dialysis should be better, because if dialysis is good, then more dialysis should be even better, then we would have perhaps subjected our patients to unnecessary higher dose of dialysis, which would have increased the cost of dialysis, which would have increased the inconvenience, and which could have increased the risk of complications which are related to the dialysis procedure itself. I think if we step back and think, we will realize that we all have benefited from the existence of this social practice, which is called medical research. So medical research actually is a social practice. And many of us who are listening to this talk and who meet each other on a daily basis would not be here if the infant mortality worldwide had not been brought under control, because most of the babies that were born used to die before reaching the age of 1 year. If antibiotics had not been invented, and take a more recent examples of COVID, if there were no COVID vaccines, or if there were no platform trials such as the recovery trial, which gave us evidence around effective treatments for COVID-19, and we'll talk a little bit more about that later on. If they were not there, perhaps some of us would have succumbed to the illness. And we will continue to benefit from these and other medical advances in future as well. So since we accept these benefits, we have an obligation in justice to contribute to the social practices. And this is the social practice of medical research which produces them. So this is a paper which was published in the British Medical Journal in 1948, which examined the efficacy of streptomycin for pulmonary tuberculosis. Now, most of us don't use streptomycin anymore for pulmonary tuberculosis, but this was such a game changer at that time that till then patients with pulmonary tuberculosis, they did not have any pharmacological treatment available to them, and if they were diagnosed, they were only sent off to sanatoria to recuperate if they could, if the body's natural immune defenses were able to overcome the tuberculosis. But in this 1948 MRC trial, streptomycin actually was shown to be a successful treatment for pulmonary tuberculosis. Now, starting from there, we are 70 years or 75 years down the road from there. And here is another example which shows that the survival rate for childhood cancer has quadrupled over the last 4 decades and now exceeds 80%. So 8 out of every 10 child or children with cancer will actually survive. This has been made possible by a number of groups, individuals, organizations, etc. But I'd like to draw your attention to this group called the Children's Oncology Group. 90% of children with cancer in the US receive care in centers affiliated with this network called the Children's Oncology Group. And more than 60% of children with cancer, and this figure may come as a huge surprise to you, are enrolled in clinical trials. So they do receive treatment, but they receive treatment as a part of clinical trial. And it is these clinical trials which have improved the survival rate of children with cancer so dramatically. We also know that research findings influence clinical guidelines and protocols. This is one such example. On the left hand, you see the paper which describes the results of the Credence trial, which was a trial of canagliflozin on patients with diabetes and kidney disease, which showed that canagliflozin significantly reduced the risk of adverse outcomes, development of cardiovascular disease, doubling of serum creatinine, death, and cardiovascular endpoints on top of treatment with ACE inhibitors or angiotensin receptor blockers, and it was quickly translated into KDIGO guidelines, which is shown on the figure on the right. That SGLT2 now has become one of the frontline treatment agents for patients with diabetes, and especially those who have kidney disease. But despite all of this, what is the current scenario of clinical research? It's a sad commentary that, in contrast to the 60% figure that we saw for children with cancer, only 5 to 10% of all eligible adult patients are engaged in clinical research. In fact, challenges in recruiting patients delay or sometimes prevent the completion of many clinical trials. Participation rates are lower in certain patient groups, certain physician groups as well. Many physicians don't want to enroll their patients in clinical trials because they think they know already what is the right treatment, and they don't think of the need for generating more evidence as something that is of concern to them. We also recognize that there are challenges. The process of generating medical evidence is slow and sometimes inefficient. And the generalizability of trial insights is threatened by narrow settings in populations. For example, clinical trials, if it is done only in an American population or white population, we will somehow not find it very easy to be very confident of its implementation or applicability in Indian population or Black African population or the Chinese population, etc. What has happened over the course of last 50 years or so is that research and clinical practice have become siloed, or they sit in separate categories. Even in institutions which should be doing research as part of their mandate, they have set up separate research, accounting, and patient information systems. So the hospital information system, wherever it has been set up, it is used for maybe administrative purposes and to some extent for clinical care, but it is not available for research. Engaging patients in research, such as screening, consenting, and coverage of care, etc., is felt to be time consuming, and it is often inadequately reimbursed by the hospitals also. In some instances, there are cultural incentives. The hospitals don't give protected time to the clinicians. The clinicians are always very busy and don't find time to do research because they think that the clinical care and their responsibility to patients is much, much more important. And they don't have any incentive. In many hospitals, doing research is not thought to be as something which is over and above clinical care. The regulatory challenges, ethics committees are often difficult. You have to take permission from so many regulators like DCGI, sometimes the Health Ministry Steering Committee, etc. And finally, we do recognize that sometimes research systems are set up in hospitals, such as clinical coordinators are hired when funding is available. But when funding gets over, there is no way to continue to support those clinical coordinators, etc. And the hospitals don't invest in supporting that cadre of workers because there is no other type of research going on there. Now, and this is another concept which was put forward by Dr. Barry Friedman in a paper in New England Journal of Medicine in 1987. And he says that the ethics of medical practice grant no ethical or normative meaning to a treatment preference, however powerful, that is based only on a hunch or anything less than the evidence which is publicly presented and is convincing to the entire clinical community. So if I treat someone just because I have a hunch and I feel that that's the best way of treating a given individual, that will not be an ideal clinical scenario or clinical practice pattern. And he says that patient or persons are licensed as physicians only after they demonstrate the acquisition of professionally validated knowledge, not after they reveal a superior capacity for guessing, which is often sometimes many of us are guilty of. And to the extent that Dr. John Harris in this paper in Journal of Medical Ethics says that scientific research is actually a moral duty for all of us. So what is the difference between clinical research and patient care? In patient care, we focus on an individual who is in front of us, either across a table or on a bed when we are rounding. But in clinical research, we focus on groups of individuals or populations. Why it is important for all of us to really be involved in this is that one of the core values for medical professionals by many organizations, and here is a set of values that was identified by the British Medical Association. And here in the bottom, in the middle, you see the spirit of inquiry, which is what is critical for conduct of research. So I hope that I have been able to convince you that clinical care and research are interconnected. Uh, Clinical care informs research and vice versa. Research informs clinical care. We all know that evidence-based medicine now is critical in clinical decision making. And the example of the last point is given here from on this slide of how understanding of research is required for good clinical practice. Again, I repeat myself when I say that there is now an increasing use of clinical practice guidelines. There are more and more standards and protocols which are being developed and are required to be followed. Quality assurance programs are being developed, and we will require to adhere to those quality assurance programs. Our patients are also more empowered because they have a number of information sources available to them. For example, Google, and now the large language models or chatbots, ChatGPT, Google Bard, etc., where they might do their own search and find out what is the right way of going about a particular treatment approach or diagnostic approach. We have to also recognize the real world situation, which is one of increasing litigation where defensive medicine is increasing. And defensive medicine does require us to make sure that we practice medicine which is based on evidence. Decision support tools are being developed, and those decision support tools also depend on high quality evidence to make sure that they work in the appropriate way. And future will actually have more and more of this when the artificial intelligence enabled clinical care will become more reality. So just two examples from the most recent KDIGO glomerulonephritis guidelines. And it says here that if a nephrologist makes a diagnosis of IgA dominant glomerulonephritis or IgA nephropathy, one of the things that they should do is to enroll the patient in a disease registry, which is a type of observational study. And in terms of treatment, given the fact that there is a lot of uncertainty about the most effective and safe treatment for patients with IgA nephropathy, the first recommendation after diagnosis, and if we feel that the patient is at high risk of progression, which is characterized by proteinuria of more than a gram, and maybe declining kidney function, the first thing we should do is to look for a clinical trial which is maybe underway in a nearby center, and consider enrolling that patient into a clinical trial. So once again, just to repeat myself, clinical care and research integration improves patient outcomes, enhances evidence-based practice. It allows faster translation of research findings into clinical practice. It is also critical for professional development and satisfaction. We all feel happier when we learn something new, when we contribute to new knowledge, etc. It allows us to use resources also more efficiently. It promotes a culture of learning, innovation, and continuous improvement. And when patients are participants in research, they feel empowered also. And empowered patients have greater degree of trust in healthcare providers. This is something which we have often lamented about, that the trust in healthcare providers is decreasing on part of the patients. But when the patients are engaged more effectively, such as through clinical research, they will also develop greater degree of trust. Having said all of this, we should not minimize the challenges of integrating clinical care and research. I did talk about time and resource constraints and the challenges in balancing research priorities with patient care priorities. We also have to add to that that most of us did not receive training in research during our medical education. Most of our hospital environments perhaps do not provide an enabling ecosystem to promote research. I had already discussed the challenging regulatory involvement and ethical considerations, etc. Then this is changing now. There is a significant culture change. Trial networks are being set up, including in India. Patients are getting more and more engaged in clinical research, clinical trials. This culture hasn't taken off as much in India as it has in many other countries. So I would encourage you to identify if there are any patients in your practice who you think could be aware and be willing to support development of research. I would be really obliged if through Dr. Umesh Khanna or directly if you could get in touch with me and share with me their details. Of course, there are new trial designs which recognize the realities of clinical practice much more, and our outcomes are becoming more and more standardized. So, talking more about new trial designs. So here are the differences between the two types of clinical trials. On the left side, you have the standard explanatory clinical trials, which we do on a regular basis. But on the right side, the pragmatic clinical trials are trials which are based more in routine patient care. So you can see in terms of eligibility, the explanatory trials have narrow eligibility criteria, whereas in pragmatic trials, we have really broad eligibility criteria. A recruitment is done in the clinic. Setting is often in a usual care setting. The organization that does it is the standard clinical infrastructure, doesn't require a separate research infrastructure. The protocols are often more flexible, and the follow-up is done using available metrics, and no special tests or no special parameters are collected as a part of follow-up, and the outcomes are usually relevant to patient, etc. So that makes it much more applicable to routine clinical practice. Now, this was really driven home during COVID-19 pandemic. So let's look at the first 100 days of this very, very famous platform clinical trial called the recovery trial. So when we look at it, January 31, 2020, this recovery trial was primarily conducted in UK by the UK Medical Research Council, and the National Health Service or National Health System was highly involved in this. So on January 31, 2020, the first COVID-19 cases were confirmed in the US. The first death was reported on 5 March, which was just about a month and a few days later. But within the 5 days of that, the first protocol of the trial was ready. On 13th March, it was submitted to regulators and ethics committees. And in 3 days, regulatory approval was obtained, and a letter was sent to all hospitals to recruit patients to this trial. Ethics approval was obtained a couple of days later, and next day, the first patient was involved in recovery. And as it turned out, just 4 days later, a national lockdown was announced. But look at this. The first patient was enrolled on 19th March, and by 3rd April, which is less than 15 days, 1,000 patients were enrolled in recovery. 10,000 patients were enrolled in another 1 month. And the first results were announced in June 5, which is just about 2.5 months after starting the trial, and which showed that dexamethasone was superior to no use of steroids, and that became the standard practice and has perhaps saved thousands and thousands, if not hundreds of thousands of lives due to COVID-19. So it illustrates a number of relevant points, which most of which I have already described, but I would recapitulate and reiterate, which is randomization as part of routine care is something that was embedded in the national health system in the UK during COVID-19. And the research community and the clinical care community also provided an open, collaborative, and coordinated response. They prioritized clinical research, and through the entire process, they removed a number of barriers in research. And eventually, it contributed to the UK clinical ecosystem into becoming a learning healthcare system. However, many of you might still be skeptical and you would say, no, I'm not interested in research. Uh, so, to all of you, what I would submit here is that you may not be thinking broadly enough about what research actually is. All of us, every clinician, is responsible for evaluating our own practice. So, that also is research. We need to be able to critically review research done by other colleagues also if we have to practice in an evidence-based fashion. And we have to learn to apply clinical practice guidelines to our setting, which also needs an understanding of research. I will present to you that there are a number of situations which provide you opportunities to participate in research. And this particular graphic shows you the phases of translational research. So obviously T1 research is bench research, the most basic type of research, which you may not be interested in. But I think all the clinicians can be involved in all the subsequent phases of research. The bedside research, could the intervention work in humans, which is through clinical trials? Does it benefit patients? Again, clinical trials. And fourth is the implementation trials of looking at how can it be delivered reliably in practice, and does it improve public health, which is T4 trial. So the question that you might ask now is, how do I start? And I said we can have a separate session discussing this, but I would really encourage you to look at this book by this famous US-based surgeon, Dr. Atul Gawande, who has written a number of books, but here are a few statements that he has made in this book called Better. He recommends that all clinicians should observe and count something that we find interesting in our own practice. And he says that counting something interesting can lead to learning something interesting. All of us should ask unscripted questions. There are no stupid questions, and we should talk to our colleagues. He also recommends that we should write something. And in the end, he says that we shouldn't complain and be prepared. We should all be prepared to change ourselves. And the last characteristics he says will make us what he describes as a positive deviant, and someone who can make a big difference in our healthcare scenario. He goes on to say that better is possible. It does not take genius. It only takes diligence and takes moral clarity. It takes ingenuity, and above all, it takes a willingness to try. So the next question that you might have is that, are you interested in simply observational work or experimental studies also? Both are very, very important and provide significantly useful clinical information. Observational studies are cross-sectional studies, case series, case control studies, or cohort studies. And for this, you might want to identify participants, observe and record their characteristics, look for association, and describe novel observations. For this, you will need to have a very good database management system for your practice, where all of this information can be recorded, because only by having this data available, you will be able to look for association and describe novel observations. But you can be a bit more adventurous and want to do experimental studies, which are trials, which can be done before and after type studies. They can be comparative trials, randomized trials, etc. And again, here also we have to identify participants. We have to place them in a common context, which is by inclusion and exclusion criteria. And then we have to implement some intervention. It could be a drug, or it could be a device, or it could be a type of practice change, etc. And in the end, we observe and evaluate the effects of these interventions. So the opportunities for clinical research in India are increasing, and this is an example for nephrology. And I described the Indian Chronic Kidney Disease Network, uh, which in which a number of centers in India are now participating. And so, what you can do is, first of all, to identify your interest, and your interest will most likely align with your practice and your patient populations. So, you can attempt to join such a research network that I have shown here on this particular slide. You should look for capacity building opportunities such as research fellowships. And we at the George Institute for Global Health have a number of capacity building opportunities. And please, again, if you're interested, get in touch with me. You should stay abreast of advances in research methodology, and of course, for those who want to do even more, identify funding opportunities, and some of the funding agencies are shown here at the bottom of this slide. So coming to the end, I would say is that in clinical care and medical care, we our focus is somewhat distinct, but also very strongly overlapping. What we need to do is to increase this overlap, as shown here in the box at the bottom, by bringing in patient-centered medicine closer to patient-oriented research, which will allow us to practice evidence-based medicine and also generate evidence which is based on medicine. Experiments and observations will help in this process. Uh, Patients can become research subjects, doctors can become researchers, and by doing all of this, you generate useful information and benefits for current and future patients. This will allow us to quickly apply research results also, and this will help us remain consistent to the principle of autonomy and non-maleficence, which is not do any harm. I will end by this quote from John Maxwell, which says that if you don't try to create the future you want, you must endure the future you have right now in front of you. So, thank you very much for your attention, my dear friends. I hope that I have been able to give you a sense of why clinical care and research should be integrated and should be done together, not in silos. And as I said earlier, if you are interested in learning more, please feel free to get in touch with me and remember this motto. And this is not something which is new, and this is by the Shankara Kshita, who was the abbot of Nalanda University, which is one of the oldest, or perhaps the oldest university in the world. And according to him, obviously from Sanskrit translated into English, always investigate, always argue, and always reason. So once again, thank you very much to all of you, and thank you very much to Dr. Umesh Khanna for giving me this opportunity.